now I feel that was like a pioneering time, but at the time I didn't realize that.
I think first and foremost, you are a great clinician that puts a lot of focus on excellence. There have been a lot of innovations you brought to the market, books you were writing, articles. What is the achievement looking back that you are most proud of?
I would say I'm most proud of, in general, is that I think the techniques and some of the developments that we have made is making the clinicians and the patient's life much better and much more predictable.
Welcome to ProTalk. Welcome to the Pulse of Dentistry. Welcome to this episode where I'm thrilled to have a very special guest today, which is Professor Dr. Istvan Urban from Hungary. Welcome, Istvan.
Thank you very much for having me here.
It's a great pleasure to have you in this podcast episode. Looking forward to our conversation. And Istvan, you have a very interesting journey behind you from Budapest to California and back. You innovated techniques, you teach a lot of clinicians surgical techniques in vertical and horizontal bone augmentation. You are a great lecturer. And I think first and foremost, you are a great clinician that puts a lot of focus on excellence. You have a great education journey behind you. I learned you are a DMD. You have a medical doctor as well. You have a PhD in periodontology, and I think for what you do today, the very demanding cases you do, you probably need all of this to really succeed. So for the ones that don't know you, Istvan, who is Istvan in 1 minute?
Istvan is a dental professional from Hungary. He was born in Hungary, raised in Hungary, and was very, very interested in medicine also and in dentistry and the whole journey. And he wanted to do the perfect bone graft. And that's all was his interest.
So that's really what was driving you. But where did this interest come from?
Well, that's actually it was not coming from originally. I was just, interested in, I went to dental school and, I became interested in the whole body. So that's why I went back to medical school. Then I started to really like dentistry, but I did not really find my field yet. And then I started to buy books and I really wanted to learn more and more. And then eventually I started to like surgery, and then I was exposed at UCLA, in bone regeneration. And then I knew that this is what I want to do. So it was not immediate. And that's good news for any young clinicians who or young dentists who you don't really find yourself, but you feel something internally that is there, and you want to connect that internal self with something. It's not going to happen necessarily in one day.
Yeah. So was this something that your visit and stay in the UCLA brought out and then really gave you a new direction or made it clearer where you want to go?
Yeah. So when I went to UCLA, I had the Carranza book, and which is a periodontology book. Which it was very interesting that I spent a couple of months in Los Angeles with some of my friends and relatives, and I was working as a dental assistant. They called me Steve. And they didn't know where Hungary was, by the way. They heard about Europe. And so anyway, then I saved some money. I bought the Carranza book. And I was really fascinated by periodontology. And that's, Carranza book is from UCLA. And that's when even after all my other schools, like I went back to oral surgery, I went back to medical school. And after that, ended up at UCLA because of the Carranza book.
Okay. So that's where your journey...
And then it came. It was already there, implants, and then it came,
So UCLA, and then there was also Loma Linda, very closely connected to this. And we just spoke about this before the podcast reporting. I mean, these have been really pioneering times when you have been there in Loma Linda doing first immediacy cases. So how was this? What did you take from your stay in Loma Linda?
Yeah, so when I went to UCLA, I already felt like that, the pioneers were way ahead of me, but the real pioneers, but I already felt like that we're like we came so late into this. And so when I went to, from there, I went to Loma Linda University, where I, met Dr. Jaime Lozada and Dr. Joseph Kahn and Dr. Philip Boyne. And Dr. Joseph Kahn, for example, was involving us in immediate implants. Mm-hmm. And so I had, several patients with him, and we did maybe one of the first customized healing abutments together, and flapless surgeries, immediate loading. So now I feel that was like a pioneering time, but at that time I didn't realize that. I realized that, like we were looking at the little details, okay, what we have to prepare for the surgery, how we're going to do it, how will I extract that tooth without breaking the buccal bone. And so at that time we felt like that everybody do it. We thought everybody's doing the same thing. Yeah. And it, appeared like years and years later that, we were doing in the 90s immediate implants and bone graft stuff like that. Not everywhere was done.
Yeah, also flapless procedures you already did, and customized abutments, which was very new then, or very, let's say, experimental. So very exciting time. So if you look back on your journey, who would you say have been your one or two great mentors that you say, look, these guys really made a big difference for me?
So when I went to UCLA, I met two of my very important mentors at UCLA. I would have to say that I looked at him like a god, was Dr. Henry Takei. And he, if somebody wouldn't know that he's the father of the papilla to me, and one of the fathers of mucogingival surgery, and he's a great person, great teacher, and a great human being. And I was kind of like, out there from kind of like Eastern Europe, and he was always a little bit paying attention to me and supporting me. The other person was Dr. Sasha Jovanovic, who was one of the fathers of guided bone regeneration. So these two together gave me a very important foundation. And I really learned a very strong foundation principles. And then when I went to Loma Linda, it was Dr. Jaime Lozada and Dr. Joseph Kahn. Mm-hmm. And Dr. Lozada is one of the most important mentors for me in multiple ways. Number one, he's maybe the most experienced person in sinus grafting. So I was learning sinus grafting from him. But when I went to Loma Linda, in the first week, I told him at lunch that I want to do vertical reaugmentation. And the spoon stops in his hand and he says, on a human? It was 1999. I said, yes. And, I was asking again, he didn't say anything, but he was the first one after 2 months. And he said, you know what, maybe you can do it. I'll give you a patient. And he was giving me a patient, and he was giving me more patients. He was supporting my tuition. Mm-hmm. At the end, I was in the bank all the time to try to, take a loan. And he said, look, if you can do this, I'm going to, support your tuition. And so I had very good mentors, I have to say.
So he identified the talent in you, obviously. Huh? He was the one supporting you.
Yeah.
Do you reflect sometimes today that, now you are in a position that you influence a lot of young guys positively, right? I mean, you have hundreds of clinicians coming to your Urban Regenerative Institute to Budapest and in your lectures. So today you are the influencer and the mentor. Do you reflect sometimes, and are you proud of this?
Yeah, I'm very proud of this, and we really would like to support as many clinicians as possible. And I really feel like that I want to support them in a way that they grow further than I am growing, where I've been growing. And I'm very happy if I would, I don't want to have any reservation. I want to give it all to them, mm-hmm. because I want people to develop and to have your next generation and the next generation. I think that's very important, because what I felt from my mentors, they gave me everything.
Yes.
And I always say that a teacher who was my teacher, is my teacher and will be my teacher. And I think this is how, when you teach, this is how you should do with all your students. Give them anything you can.
Uncompromised,
everything, without any reservation.
Yeah. So for the young generation, what would you say, what does it take to really build a long-term, successful clinical career?
I think the basic principles will not change in life and in this. The basic principle was and will be, I think, that you want to do good care for the patient. And I was always very lucky to be very interested in this and very passionate about this. But I see that in many of the young individuals. And I think one of the best advice that I could give is to look always that you want to do a better job. And for example, I was never dreamed of becoming like a lecturer or invited here or there. I think that's not the best goal to have. If I would be young, or I would tell my son, it's your dream is not necessarily, okay, I want to be in this podium, I want to do that. No, I want to do very good work. I want to do a very good job. I need to be passionate about this. And then if you do a very good job, you can go anywhere.
Exactly. Yeah. Then success will come.
Yeah.
But the foundation
success
is
will
excellence.
Come.
Yeah. The foundation is excellence, right? That's for sure, yes. So you got a lot of inspiration from great teachers and mentors, I learned. And I can feel the emotional attachment you still have to them. What is inspiring you today? Because I mean, you are still in the middle of your career. You still have this hunger to progress and this curiosity. What is inspiring you today?
I realized in the last couple of years that, when people are talking about retirement, and I realized that I don't understand what that is. If I would feel that I want to retire, then I would be very disappointed in myself. Because I feel that I'm very, very interested in this still. Oh. And what is inspiring me is to really have a couple of visions that, what could be better, what we could do better already. It's already maybe here, we could do it, but we're not doing it because of this or that. And we don't have all the support or, things like that. So what I would want to achieve, and I would like to treat a lot of patients, to train people who can treat much more patients than I can treat. And, I'm very lucky that I'm very, very interested in this. I think it's luck.
So your passion will carry you for many years.
Yeah, I'm not afraid that I'm
good.
not going to be interested.
That's good. Okay, that's excellent. So you are a great clinician, a teacher. You write books. You're an author. You're lecturing. You're traveling a lot. You have a family. How do you keep your balance, Istvan?
It's very difficult.
I can imagine. What's the secret to your balance?
I would have to say one of my luck that I was never like a party person.
Okay.
So I really like to go home.
That's good.
And I really like to spend time with my family. I always like to spend time with my children. When I had to travel, I would do the worst thing for me in traveling was that tomorrow I cannot tell the evening tale for my kids, which I really enjoyed, when we go to bed and yes. The evening tales. So I did always the three things, basically. Apart from my profession, most of the time I spent with my family, and I really enjoy that. That gives me a complete fulfillment. And the third one was I was always doing sports, which was very good for me to regenerate myself. So these three things to me is the full picture. Is a full life, gives me a full life, and this gives me balance. But I don't have to go out, to a pub yes. 2 times a week and get drunk, for example.
Yeah. I think this discipline, it pays off for the long term. I'm pretty sure. On your Instagram account, I saw quite some nice pictures. You on the kayak, right? Is this yes. your favorite summer sports? Because I know you also like to do ski tours in the winter. You're a good skier.
Yeah. Yeah, so sprint kayaking is my favorite sport. However, I was never, very talented in it. But I tried many sports when I was a kid, and this was the one that I really liked. And I still do it, and I have friends who we know each other I started like 40 years ago or more. And we know each other since then, and we meet, we train together, we enjoy this a lot. It's out there. My kids were kayaking, and so I'm trying to do it, before and after work, if I can.
Your kids, that's a good That's a good word to catch up. I saw your son is a quite talented musician. He's building a career around musician, and I know that you're supporting him big time. How important is this, and what is your role for creating his career and supporting him?
I always believed that I want my children to become what they want to become, what's in them, and I don't want to, tell them what they should be. and I think it's going this way really well. And he was. Ishti was very good in school, very good in mathematics. He was always good in music. We put him to music. He was very good in music. And the music teacher told us that he should be a musician. And I even told him, I said, no, I want to be a doctor. And then he started neuroscience. He did finish neuroscience, but he went back to music. And he wants to be a musician. And I completely support it because I see that he is happy with this. And I really believe in him. And I believe that he can be successful with this. And I really enjoy supporting my children that they become what they can be.
Yeah, so really supporting their talents.
Yeah, I really support it.
So let's switch a bit gears. Let's slowly but surely move into dentistry and the field what you are famous for, which is clearly regeneration and surgery. So there have been a lot of innovations you brought to the market, books you were writing, articles. What is the achievement looking back that you are most proud of?
That's a very good question. I could say that I'm most proud of one technique. I would say I'm most proud of, in general, is that I think the techniques and some of the developments that we have made is making the clinicians and the patient's life much better and much more predictable. And I always say that I wish I could talk to myself 30 minutes 25 years ago.
Okay.
Because that would already be a big help.
That's a very interesting mind experiment, I have to say, yes.
Yeah. But, of course, I'm very proud of the sausage technique, not because it's very popular now, but I think because it's just significantly simpler and less invasive. Mm-hmm. I'm also very proud of some things like how you can manage protection of the mental nerve, protection of the elevation of the lingual flap, how you can minimally invasive reconstruct soft tissues. I'm very passionate about the papilla. That's coming already from UCLA.
From your teacher, yes.
Yeah. And I'm very proud of some of the achievements we had. And I'm very proud that we published a paper together, 2 papers together with Dr. Henry Takei on the papilla.
Yeah, that's the biggest one, if you can publish together with your teacher. Yeah. Let's go back to one technique that you mentioned, the sausage technique. When you invented this, the gold standard technique was much more invasive. I think it was the Gore-Tex technique, and I think there were also soft tissue dehiscences and issues that clinicians would see. Now, today, the sausage technique is clear and it's obvious, but, there was a starting point at one point. And, I wonder, how did you have the idea to come up with such a different technique? Because I think it takes a lot of thoughts and, you need to be very mindful about this. How did you come to this idea?
So I always documented all my cases and really well. But I took, pictures of everything, but basically for myself. I never thought that I'm going to really show it anywhere. And in 2003, I had a patient where I did a big vertical ridge augmentation, and that patient developed 3 fistulas 3 weeks later. Soft tissue healing was perfect, but 3 fistulas clearly indicated that there's an infection. And so I was shocked. I thought, how can you get an infection when the tissue is closed? Anyway, so after 2 sleepless nights, I called the patient and patient said, yeah, I have no problem, don't touch it. I said, no, we have to get back in there and clear the infection out. But it was 3 weeks old. And at 3 weeks, I removed the Gore-Tex membrane. And what do you expect? In 2003, you remove at 3 weeks a membrane of vertical augmentation, the whole thing will collapse. So what I've seen was that there is this ridge, and on the surface, there was a grayish area that I washed out, but the rest of the bone graft was sitting in a blood clot, almost talking to me, don't touch me. Just give me a blanket. And the blanket was a collagen membrane. I put a collagen membrane. I did not fixate anything because I saw that this fixed. I closed the soft tissues, but I told the patient, look, we remove this membrane, and this membrane is very important. This membrane has to be there for 9 months, otherwise we're not going to get bone. And I'm so sorry, but very likely I'm going to have to do another bone graft. But let's wait. We didn't have a CBCT, so we just, I took X-rays, but the X-ray, it doesn't look so bad. So then in 6 months, I went back, I opened up the flap, and the entire bone that I kept at 3 weeks was there. And I had all the pictures, and I started to look at the pictures. I said, look, you know what? Maybe this resorption time is not so important. And maybe if I could initially fixate with a collagen membrane or a resorbable membrane, a bone graft, at least for a horizontal direction, that could work. Now, 2003, I told this to some of my mentors and friends, that this is what I'm going to do. And one of them said, this is the most stupid idea you can ever have. You're not going to get anything. But I already did it. And 6 months later, I send the picture. I got this amount of bone. No, this is by accident. Oh. Next one. Then I had 30 cases. Then in 2005, I was at the AAP. They had like a so-called sunrise symposium. Before the main symposium, it was like some university people were there. Yeah, early birds. And I presented this. And, they were like, this we cannot believe that. So then, this became like a standard for me. And I ran 2 studies on this. Wow. And really changed, one complication and one documentation of complication changed the whole thing.
So to summarize, it's intuition, because the bone was speaking to you and you listened. Yeah. It was expertise, because you have been a greatly educated and skilled clinician already then, but also the conviction that even if some people tell you it's not going to work, believe in it and continue doing it and documenting cases. And today it's one of the most famous probably augmentation techniques that there is out there and very well documented. Is it still like the heart and soul or a key element in your courses today? That people are coming to Budapest for?
It is, but today we use it for so many, other regions.
Yeah. Okay.
Like compromised sockets.
Yeah, you have developed it. Yes.
So there's like sausage here and there. We put sausage on periodontal regeneration. And so, it is... I'm going to have a presentation this year, and I gave the title of the presentation, One for All. So one technique for a lot of indications.
Because it became so predictable for you in your hands and of many other clinicians as well. I think it's a good time to have a question from the audience, because we reached out through Instagram and we got a couple of questions that I selected 2 of them. So that is Dr. Bisan Shokui. And the question was, do you think allografts have more of a place in regeneration in today's world?
That's a very good question, and it's not easy to answer. Because allografts, they have some very good properties. They're very natural because they come from a human. When they demineralize them, they can expose some growth factors that they're in there, such as bone morphogenetic protein. But on the other hand, they have a tendency to have more resorption than, for example, xenogenic bone grafts. So I would say that they have a role in regeneration, maybe not alone, maybe in combination with other graft materials such as xenogenic bone graft materials, but I would say because they have a tendency for resorption in vertical ridge augmentation, I don't really see them. Mm-hmm. But for maybe a small dehiscence, very well fixated, maybe with a collagen membrane, maybe in conjunction with a xenogenic bone graft,
there's a place.
Even though I'm not using them, but I would say I would not say that I would exclude this idea.
No, we clearly see a development of allograft materials in the European market. We know that in the US it's the dominant.
US is really
it's the dominant material. There's also xenografts, but we see the verge of allografts also in the European context. So it's a very good question. And the colleague was a very interesting colleague. There's another great question that I liked is, what is something significant in regeneration that you think we don't talk about enough?
I think we don't talk about enough we talk a lot about like how you do a lingual flap, how you do a buccal flap, how you do this bone graft, and how the bone looks. But we don't talk enough about how the bone will look in 10 years. and what are the most important factors that you have to do to make a bone graft long-lasting. And I think that's also including, I think that should be more standardized what people are reporting in regeneration in terms of implants. I think it would be better to have more studies when they report from consecutively 1 year, 5 years, 10 years, 15 years, hopefully the same patients. Because if you report like a 15 year, it could be a little bit of a cherry picking. So I think today we have much better implants than when we started. When we started with external hex, we have much better implants. We have a much more choice of implants. We have very good materials. And also, like, we have a lot of tools that we can do follow-ups. We are understanding much more soft tissues around the implant. So today, I would say that for any young researcher, to put them all together to make a very, very good regeneration, but also think about, that this patient wants to chew on that.
But on the flip side, it would also tell a young clinician, focus on techniques that have proven to work and are documented well, right? I see a lot of trends on Instagram on surgical techniques that I'm not so sure if they are well documented already. I'm not a clinician. But it would also tell the clinicians, focus on what has worked in great clinicians' hands and what is, let's say, well documented over quite some years.
Yes, but going back to the sausage, which was completely not documented before because it didn't exist. But I think, when you look at something which has which biologically sounds and common sense and biological sound, like sound biologically sound, so that makes sense. And there's a common sense that if you maybe two variations together, that should work. That has to be studied, but this is how it should be developed, like new techniques.
Yes. I would add another question that I had, let's say, to the allograft technique. We see a lot of techniques coming now with hyaluronic acid. How do you see this material and the potential of this substance to enhance bone healing or tissue reaction?
So, I only used one product which has, they call it polynuclear hyaluronic acid. And, theoretically, because in dentistry it's not so well documented yet, and I think it has to be studied more in animal and clinical level. Theoretically, it's also communicating potentially with healing mesenchymal cells and also, maybe promote soft tissue healing. But also, in my experience with this, is that it helps my regenerative grafts to be more stable. Number one, because of the gel, it's like some people call sticky bone when they put like a blocker. So it's a little bit like that. That's already a big help. Anything that I try, and it's even if it's documented but it's new, first I want to try to make sure it doesn't make it worse. Okay? Yes. And I can tell you it doesn't make it worse. Okay. I think it makes it better. And I'm very careful saying it makes it better because it's on my assumption.
Yes.
And your assumption is not so objective. Okay? So, but I would say, I think it makes it better. I think it makes it more stable. I think it makes it more easy. And very likely, you can help also soft tissue healing with it.
So hyaluronic acid, you see the potential in it?
I do see the potential.
But you feel that there needs to be more documentation?
I think there needs to be more documentation.
Yeah, okay. Because I see this as a big trend, that there's a lot of products coming to the market and there's a big fuzz around it, and I understand the potential and the attractiveness of it.
It's very likely not very expensive too.
Exactly, yes. That's another one. Yeah. So if we look a little bit back, let's say in regeneration, in dentistry and implant dentistry especially, what have been the big changes and breakthroughs the last 10 to 15 years from your perspective?
I mean, for implants, the development of implants. I think I would say two things. One is the screw design, that you can do more immediate cases, okay? Which was, we know all these implant names that was developed for immediate implants. I did all the immediate implants. And, these newer, screw designs, they make your life much easier. Then you can really put, you don't have to put a customized finger button, you can put a crown on it. Yes. That's one. The other one is the development of more hybrid design implants. implants that are, especially in the posterior regions, are friendly for the soft tissues, friendly for the users, easy to use them, and I think it's protecting more the bone and the patient. So I think these two, the combination of these two, is that because we really need to look at less peri-implantitis in the future and more stability and easy.
Yes. So this one I get. If you look a little bit in the future, what is it that you would love the industry to focus on in terms of innovation and technology?
Okay, so there's two things. One is let's talk about maybe the implants and regeneration.
Yes.
In terms of the implants, I think, implants that focus on easiness and prevention of peri-implantitis. And one thing is a hybrid implant, okay, that like, or tissue connection type of implants, or hybrid screw design, to make sure it's more cleansable, to maybe less bacteria can adhere to it. But I'm sure there's a lot to develop in this segment.
What do you exactly mean by a hybrid implant? An implant that has a machine surface?
Yeah, it has a machine color. Yeah.
Okay. Yep.
But I'm pretty sure that, if we talk maybe in 15 years, there will be, okay, but this will, let's say that we will cover it with something, that it's even better for the soft tissue attachment, better against bacteria and things like that. So I think this has to be,
so
very important.
Enhanced surface treatments for this area of the implant.
To prevent peri-implantitis.
Yes.
I think that's number one. And to me, that's the main goal for the long term of implants. Because I think implants will have a future if there will be less peri-implantitis.
100%, yes.
I mean, they will have a future, but they should have a very long future.
Yeah.
And then in regeneration, I think we're not practicing what the potential is today.
Okay.
I think today we're still taking I also take a lot of autogenous bone from a patient, but I think if the industry, the research, and a clinical skill would really, all the potential would put together, I think there would be techniques when you don't really have to do that. Let me give you one example. For example, bone morphogenetic protein was licensed, FDA approved in 2007 or so. It was developed at UCLA in the 60s. They did 4 decades of research, then re-research. So they approved it. They approved it for oral surgery, for sinus grafts and extraction sockets, but nobody's using them because they're very expensive. Nobody knew how to use them. They were overdosed. And then, the company behind it is not interested in dentistry. Okay, because for them it's like, there are new research showing, for example, we did one article in the COIR, people should read it, we call it the lasagna, which is, we do the microdose, if you take a bone graft, and we do the microdose of BMP2 on top of the bone graft. And we see in 8 weeks in an animal a full new mandible. And if you look at the microdose could cost you like 200 euros instead of 3,500. Microdose doesn't give you a lot more swelling. But nobody's making a microdose. So I was talking to the company, who's making it. They said, look, we know.
But they're not in the field of dentistry.
But, it's like, for us, to do the licensing and all that is like... So just one example, I'm not saying that BMP2 is like the solution for everything, but I would say that we don't use it enough.
Yes. There's clearly a lot of potential
we don't
behind.
use it enough.
It's not easy to control, but there's a lot of potential.
On Monday, I have a big meeting, and it's going to be a very important meeting to decide if we could get approval in Hungary for randomized clinical trial with microdose of BMP2.
To put data
to do vertical rejuventation. But in a way, I have to say that to put it in a normal bone graft and on a normal bone graft and a microdose. Why not on 100% biomaterial and a microdose, which would be the most interesting for the readers, but I'm looking at the patient.
Yes.
So I want to add something better as an extra, but I know that this patient has to have the implants. So I'm not going to do like an experimental. Okay, that potentially fails in this. I will do, the best bone graft we have today, plus a little bit better. Is it going to be a little better? And then you're going to say, maybe in the future, not me, but maybe in the next clinician, Urban did maybe 50%, you know what, we're going to do 20% autogenous bone. And we compare that. Oh, and that's also good. Okay, then we're going to go for 0. So I'm just saying that there's a lot where you know, industry, research, and clinicians, if they put their head together, we could improve faster.
So this is a field where we can progress a lot. I have 2 follow-up questions. The one is a natural protein, Endogain. I mean, what is the place of Endogain in your daily clinical practice?
Okay, now I have to be honest with you. I really love Endogain. And there is a sentimental love also. And that's coming from UCLA. Okay? So we used a lot of Endogain with Dr. Jovanovic, because I was assisting him all the time preparing everything. And he was also fascinated about, you know, the papilla and the interproximal bone. And was using a lot of Endogain for this type of indications. Dr. Takei was also very supportive of Endogain. But Endogain at that time was not, you know, in some schools they were like, oh, it's endo no gain. You know, it's like, so, but then the research came. Yeah. But I always used it for around, you know, mostly single implants when the neighboring bony peak was lost. And I tried first with the soft tissue attachment, then a little bit of a bone graft, and then a connective tissue graft on the neighboring tooth. And then when I didn't have money to buy, and the patient didn't have money to buy it, then I didn't use it. And I felt that the result is good, but it was not so stable. So I had a popular, but in 2 years it started to go. I have a patient that we published with Dr. Henry Takei, 21-year follow-up, with one of the biggest popular regeneration, the first popular regeneration article, one of the biggest popular regeneration I've ever done. It doesn't change at all. So I do have that. So I do have a kind of like a sentimental, but a very objective love for or use for it.
Yeah. I remember we met at the 30 years of Endogain symposium in Vienna at the Europerio 11. Yes. And you already were quite passionate about it. And it's amazing technology with so many long-term studies, 1,700 studies documented, millions of patients that this product has helped. So it's great to see that this really still today has a big relevance in
I really hope it's a successful product.
Yeah, exactly.
It should be.
Second follow-up question. You mentioned the topic of peri-implantitis, and I loved what you said about the hybrid implants and surface texturing to prevent peri-implantitis. I believe this is a field we need to look into 100%. But still, you know, today peri-implantitis, we know it's a reality, and we have to take it serious. And we as an industry partner or the leader in dental implantology, we want to take this serious. What is your standard approach today if you find patients that have an issue with peri-implantitis? So
I find them, and most of the patients that I find are my patients. Okay, I'm not saying that I have a lot of peri-implantitis, but I have to be honest. I have patients who come back to me and there's some peri-implantitis. And so before, I would say I was very unsuccessful. Because when my very first lecture in my life was about peri-implantitis in Loma Linda, 99. Okay. Because my very second patient they gave me had peri-implantitis. And so I did this peri-implantitis lecture because they told me I have to give a lecture. And I can choose the topic. And I chose peri-implantitis as a topic, 99. And so anyway, then we tried everything. But at that time, you know, we were polishing the implants. And that was, for a long time, that was the most successful for us, you know, like resective surgery, polishing the implant. And sometimes it worked perfectly, sometimes it didn't work. Then, you know, recently I started to use then use lasers, then use powder, chemicals, doxycycline.
You tried everything.
I tried everything. And nothing was satisfactory. So it was pretty unpredictable for me. And then recently we started using electrolyte on the implant. And, you know, they gave it to me, so I put it on. When I removed it, it was like, oh, that implant really looks clean. Wow. And so in very well selected cases, we started to do like really regeneration in a way that we said, okay, if we clean this implant with something, maybe with this electrolyte, it looks like it's clean, then the principles of regeneration can be applied. For example, sausage technique. Submerged or transmucosal healing. And we started to look at, okay, how many walls we have. Like in normal regeneration, like if it would be a new implant. And if it's a new implant, how would I regenerate this? And that's, you know, like it's a little bit of a step back.
So the cleaning is the key part.
Cleaning is key, because if it's clean, then you can do whatever you could do with a new implant. And we came as far as I'm embarrassed to say, we came as far as that I have implants that are regenerated vertically. Not that I would say that you have to do it or you have to do it regularly, but that if you can do that, that means there's a potential there. And then, most of your cases, you should go back very early when the wall is like 4 or 3 walls, when it's easier to treat for anybody. If you can clean it, you can do much more success with peri-implantitis treatment than, previously. Even though, I really admire all the people who are doing peri-implantitis regeneration and all these treatments. But I think it was more limited before. Today we have.
What is your experience or your early experience with galvo surge? Because I know you.
Yeah, that's what I'm talking about. That's galvo surge. Electrolyte is galvo surge.
Okay, and this worked well for you?
It worked really well for me.
Okay, for the cleaning and then to make it.
I'm not saying 100% always, but it's by far better than anything I used before.
Yeah. No, I'm happy to hear this, because I think it's really something that we owe to the patients, that we also have a way to treat peri-implantitis cases, because these cases do happen. And I really like the fact that you also say, look, it's also my own patients, because usually I hear clinicians say, look, I treat peri-implantitis, but it's not my own patients.
Yeah, no. So everybody has those patients.
I think that was a very important statement that you made. So coming to the end, Istvan, how do you see dentistry in 10 years from now? What is your vision of dentistry in 10 years from now? It's moving fast at the moment.
I think it will be a lot of digital, and I would say much better digital. Today we're in the digital phase on a very, very advanced phase, but it's still like a hybrid, digital and analog. We had patients who, we did whole digital design of the upper arch, and then the patient had, maybe the phonetics is not there, and then, we have one of the colleagues who's very, very good prosthodontist is doing a lot of digital, but then he sat down and for 3 hours he was adjusting by hand, and then, it became perfect. But that's not fully digital.
Exactly, yeah.
No, but I would say that this is going to improve a lot in regeneration also.
That would have been my follow-up question. How do you see digital in regeneration? Because today I believe we speak digital, we speak about smile design, we speak about guided surgery, guide production, we speak about prosthetic design, prosthetic manufacturing. We are not necessarily speaking about digital in regeneration. How do you see the role of digital in regeneration?
But number one, there's some digital already, they're printing bone blocks, they're printing meshes, which I think is a very good improvement. But I think this is going to improve much more. So, for example, if I want to print something, I want that to resorb. Okay, I don't want to print something that is going to be very difficult to remove. And it will incorporate into the soft tissues. And, I want to give my diploma back by the time I raise the flap from it. So I want to do something which is simple, which is very tissue friendly. Hopefully resorbs. Maybe I can tell that when to resorb. Dependent on, I can customize, okay, well, this is the defect, okay, well, this vertical defect, I think, or I know that I need 4 months. And I'm going to print something and tell this synthetic, whatever, PCL or something, that this is going to resolve in 4 months. Okay, this is like maybe a very soft printed sausage shell. Okay, but this I want in 1 month out of there. And things like that. Also, in terms of the now I was talking about, like in terms of shells, but maybe you can print the whole bone graft and you can spray growth factors, you can spray cells. That's not in 10 years.
Yeah, maybe not, but it's, I think it's important and good to have the vision.
Yeah, but this is like, I think that you should have an end goal is this.
Yes, exactly. I think it's good to have a North Star and a vision that we can work towards. So even though we know it's going to take long, but I believe that digital and regeneration, that there's a lot of potential already in the next 5 years, that we can do much more. And happy to hear that you also see the potential and this being realistic. So Thanks a lot for the conversation, Istvan.
Thank you
I
very
experienced a very passionate clinician and researcher, passionate about doing great work for the patient first and foremost. I think that was a very strong takeaway for me. It's not about being on stage, it's about doing good for the patient and doing great clinical work, and the rest will come. I think that's a very important message. And also the innovative part I liked, and having this intuition, seeing something like the sausage technique, and having also the willingness to believe in it and follow through, and making this a great technique that people love to use today, 22 years after you had the idea of it. So congratulations on this. Thanks for being here.
Thank you so much for having me here, Andreas.
So thanks for listening in to this episode of ProTalk together with Professor Istvan Urban. Look out for the next episodes, and as always, we like to interact with you. If you want to share a comment, please do so on all the podcast platforms. You can leave comments, you can ask questions, and thanks for listening in, and see and hear you next time. Thank you.